Welcome to another online tutorial covering aspects of the Royal College of Anaesthetists initial assessment of competencies. This talk is going to cover patient transfer and positioning for surgery as part of the IAC D02 requirement. In this talk, we're going to cover a few things. We're going to understand the role and responsibility of the anaesthetist in transferring patients to the operating room. We'll describe some of the common positions for patients for surgery, understand the key concerns with the patient and when positioning them, and as always establish any other curriculum items that can be linked to this workplace-based assessment to maximise your time with your trainers. To that end, the curriculum content we're covering is IAC D02, transferring a patient onto the operating table and positioning them for surgery. And looking through the other curriculum items, I can see two others that you can link to this when you do the workplace-based assessment. The way you do this is when you submit your workplace-based assessment, you add your initial assessment of competencies code, which you can see the bottom arrow pointing towards there, and you just select IAC D02. And then if you want to add any of the other curriculum competencies that I've mentioned, then you follow the top arrow I've got there, which is add competencies, and just select them to it as well. And you'll get through the curriculum in no time at all. So let's think about patient flow to the operating table. So for the purposes of elective surgery, patients may arrive to the operating suite via several means. They're walking, could be in a wheelchair, on a bed, or carried by their parents. In the UK, they'll typically arrive in the anaesthetic room. Once they've arrived, they go through a series of identification and checks, which is covered in another one of our talks. Once they've been correctly identified and paperwork's been checked, the patient is then transferred to the place where they will be anaesthetised. So this may be on a bed, a trolley, or in fact in the parent's arms. They may well be able to get into this position themselves, or they may need assistance. The place where they will be anaesthetised may also be the place where they are going to be operated upon, which is especially the case for patients who are difficult to transfer, such as the morbidly obese. After they've been transferred to where they're going to be anaesthetised, they will then have their anaesthetic. This could be regional, neuraxial, or a general anaesthetic. And then they are typically transferred to the operating theatre and positioned appropriately. For this last step, the positioning for theatre, they will almost universally need some form of assistance from the theatre and anaesthetic team. And it's this step that we're going to focus on in this talk. So why is positioning important? Well, aside from it being a necessity for surgical access, there are multiple considerations for the anaesthetist. Many patient positions result in undesirable physiological consequences, which we'll go into later. Also, from our point of view, we have an airway in situ, and the patient will be monitored for the physiological parameters. And positioning them in certain positions may cause difficulty with either our access to the patient's airway device or peripheral cannulae or monitoring equipment. Occult injury can occur to the patients, so this can happen by a number of means, by stretching, compression or ischemia, and this can affect nerves, vessels, or any soft tissue. And if the positioning aspect is undertaken lightly, then injury to staff and the patient can occur, as well as damage to any equipment we have. And of course, any damage to person or persons can result in litigation. So it's clear why we might position patients from a surgical point of view. The surgeon will want the optimum field for which they can achieve in order to perform adequate surgery. But it's important for an anaesthetist as well, because positioning will have an impact on patient physiology. And physiological responses exist to counteract the effects of changes in position, especially when we're thinking about the cardiovascular system. And the drugs that we've administered to facilitate anaesthesia can blunt this response. So some key aspects to think about in effective physiology are thinking about neuraxial blockade can significantly affect sympathetic response. Positive pressure ventilation itself reduces venous return and cardiac output. So with these 2 points, what you need is an intact sympathetic nervous system and therefore good preload to the heart to maintain cardiac output. So certain positions that we'll go into can affect that aspect. For spontaneously breathing patients under general anaesthetic, they will have reduced tidal volumes, reduced functional residual capacity, increased closing volumes leading to a VQ mismatch, and decreased minute ventilation. And therefore, any position that limits diaphragmatic chest wall or abdominal movement will increase in atelectasis and intrapulmonary shunt. So in positioning a patient, especially if they're spontaneously breathing in a way that compromises their ventilation, can see how we may have we may impact on the ventilation, their perfusion, and their CO2 removal. So common considerations that we think about when moving a patient are the positioning and the security of that which we've put in place, so intravenous lines and any tubing and connections from them, the security of a supraglottic airway or endotracheal tube, any connections with the circuit from the tube to our anaesthetic machine. We also have to think about brachial plexus injuries when moving the upper limbs to put them in a position where we might access cannulae or getting the limbs out of the way of the surgeons. Thinking about neurovascular structures that may be impinged upon. Thinking about pressure sores. So it's common for us to go through, have a look at a patient and do a quick check to see that there's nothing that's pushing, digging in or applying pressure to areas with bony prominences that can cause tissue damage. Of particular interest, the eyes, which we'll go into in more depth later. This is mostly relevant with proning, but also a patient themselves under general anaesthesia will not be able to have a blink reflex, will not protect their own eyes, therefore we often tape the eyes, and this is a standard of care. Also, you have to think about once you've got the patient, and let's say they're perfectly protected, perfectly positioned, once that blue surgical drape goes on top of them, the surgeons themselves won't be really aware of where the patient is. Things like their nose, their face, their eyes, and parts of the body, and they may inadvertently put elbows in various places. They may be leaning onto the table, and that may apply pressure, which either injury to the patient, which is somewhat unlikely, but mostly it can affect the quality of our monitoring. And it's not uncommon that a surgeon leaning on a patient in a supine position can dislodge the oxygen saturation probe, and then we have to ferret underneath the surgical drape to fix it. So I think pressure injuries make the most sense when thinking about how we're positioning a patient for their safety and comfort. Often, actually, when if you have a patient and you're positioning them before you give a general anaesthetic, which is somewhat rare, you can ask the patient whether or not there's anything digging into them. Do their arms feel in a neutral position? Is there anything we can do to make them more comfortable? Because certainly while they're awake, they're going to be aware of any stresses, strains, and anything that causes discomfort. It's a protective mechanism, which we obviate by giving them a general anaesthetic. So make full use of them while you've got them awake, especially asking them, even in the preoperative assessment, about limits to range of movement of their arms, of their legs. If you think you're likely to have to bend knees, flex at the hips or elbows, put arms up by the sides of the head, anything like that. Now, pressure injuries themselves have several risk factors. So general anaesthetic, which we've spoken about, is a risk factor. Prolonged operating times, and that's really got a correlate between length of pressure on any part of the body and degree of injury. presence of diabetes, which can have an effect on their neurovascular supply to tissues. Therefore, tissues are at a greater risk of breakdown or will a poor wound healing. The extremes of weight. It is true that for patients who are obese and those who are underweight, that they are at greater risk of pressure injuries. Things you have to think about with the actual position that you've taken on in pressure injuries. So we're going to go through some of the specific positions soon, but clearly different parts of the body are going to be affected, whether you have someone in a supine position, in a sitting position, or in a prone position, or lateral decubitus position. So you need to be mindful of which parts of the body are going to be under pressure in which particular position. And then thinking about pressure injuries that can be caused from our equipment, such as nasal cannulae, NG tubes, cervical collars, any conducting equipment that's going underneath the patient, or running close to them if you've got arms tucked by the sides and you have a three-way tap connected to either your arterial line or your peripheral venous access, and that's digging into the skin, those sorts of things. Next important thing to consider is peri-operative visual loss. Now, this is a rare but serious condition. Broadly speaking, there's sort of three main areas that it breaks down into. Either you have ischemic optic neuropathy, ION, which is rare, about 1 in 100,000 cases, and its highest incidence in spinal and cardiac procedures. And it's got two types. There's either an anterior or posterior variant. The anterior variant being characterized by blood flow disrupted to the anterior portion of the optic nerve. That's most common in cardiac surgery. And the posterior ischemic optic neuropathy is to the posterior portion of the optic nerve. It's more common in spinal surgery. But you also have retinal artery occlusion that can occur. And this can affect the whole retina, in which case it's called complete retinal artery occlusion, or a branch thereof, in which case it's called branched retinal artery occlusion. The central retinal artery occlusion usually results from improper patient positioning and external compression of the eye, but it can also be due to embolic phenomena. Branch retinal artery occlusion usually is due to microemboli or vasospasm, especially during cardiac bypass, but either can potentially be treated with cooling of the affected eye, thrombolysis, or even simply massaging. Other causes of peri-operative visual loss are cortical blindness, so that's something that's happened actually within the grey matter in your the posterior lobes. Vitreous hemorrhage or gas expansion that might have occurred with eye surgery, or depending on what sort of anaesthetic choice you might have given with nitrous oxide. Risk factors for peri-operative visual loss include prone positioning. So when we have someone prone, the eyes should be examined every 20 minutes at least, and in fact we have special headrests that the patient's head is placed into when they're anaesthetised in a supine position. We then put them in the prone position, and we should be able to clearly see the eyes, the nose, the endotracheal tube should be clearly visible, and there shouldn't be any pressure on any of the pressure points. It should be nicely seated. Often we have a mirror underneath the headrest, and that allows us to look or to see the eyes to check that they are still closed. Because if they're open, you've got the risk of corneal abrasions. Duration of surgery is important. The longer it goes on, the higher the risk of peri-operative visual loss. Also, running low mean arterial pressures. And that's clearly has a perfusion impact. And when I went through the various pathophysiology of ischemic optic neuropathy and retinal artery occlusion, you can see why that would be important. But then there's a number of patient factors. such as anemia, hypertension, diabetes, or if they're indeed a vasculopath. Then, finally, thinking about peripheral nerve injuries specifically. So these tend to manifest post-operatively as paresthesia, weakness, tingling, or pain. And they can last for any duration, and different places have different durations of time which they consider to be a peripheral nerve injury associated with an operation. It's important to note that it is the anaesthetist's responsibility to position a patient safely for surgery. Therefore, any of the injuries that I've so far covered, and especially peripheral nerve injury, falls under our remit. So it's very important that we understand this. It's a significant source of professional liability and litigation. It's one of the top reasons for payouts, especially in the US, when it comes to standards of care. Now, there are 4 underlying pathological mechanisms. Stretch, so that's having an arm perhaps fully abducted when it's in an uncomfortable position. Compression, ischemia, or metabolic derangements that might have been caused as a result of how we're balancing the patient's physiology. In order of prevalence of how they occur, ulnar is the most common, then injury to the brachial plexus, then a lumbosacral nerve root, a spinal cord sciatic, and finally perineal. Now, the ulnar nerve, typically we need to avoid pressure on postcondylar groove of the humerus. You keep the hand and the forearm supinated or neutral. For the brachial plexus, you want to avoid shoulder braces and abduction of the arm greater than 90 degrees. You also want to avoid excessive lateral rotation of the head, and you want to keep the axillae clear. For the spinal cord, you want to avoid severe C-spine flexion or extension. And with the sciatic perineal nerves, you want to minimize time in, for example, a lithotomy position. You want to move lower limbs simultaneously when you're positioning them and avoid excessive hip flexion. If you extension of the knees or torsion of the lumbar spine can also injure your sciatic nerves. And you want to keep pressure off the fibular head. So now thinking about some of the positions that are commonly used and we should be familiar with. Firstly, clearly supine. This is the most common position for surgery, and it's characterized by the head, neck, and spine being neutral. The patient's lying down. The arms can be abducted or adducted, but the forearm should be supinated or the palms medially orientated. So that means pointing towards the body in abduction. This position, although it seems like the universal one, or the one that's likely to keep the patient most comfortable, it's actually not well tolerated by patients with marked kyphosis or scoliosis. And actually, these specific patients might benefit from a slight hip flexion. So we might have a patient in this position for abdominal procedures or for a lot of ENT procedures. In terms of the physiological effects, it's actually got limited cardiovascular effects. The body is used to being in this position. Lung volumes are slightly decreased by abdominal contents, but otherwise things are pretty much kept neutral. There are some complications, so you have to pad any tissues overlying bony prominences, like the sacrum and the heels. If arms are abducted, then it should be to less than 90 degrees to avoid a brachial plexus injury. And you have to think about the ulnar nerve injury, so think about what's going on at the elbows. Next position that we should think about is the Trendelenburg position. So the Trendelenburg position is simply patient supine and then in a head down position. It's classically described as a 45-degree tilt, but any head down position can be considered to be Trendelenburg. You might find patients in this sort of position for central line placement. If you want to improve abdominal exposure during abdominal surgery or for gynae surgery, or if your patient is severely hypotensive and you want to increase venous return to the heart, you lift the legs, the whole body up, you can just put head down, legs up and fix that. This isn't a normal position for the body to find itself in, so there are physiological effects to it that wouldn't normally anticipate. So there's increased cardiac return and therefore cardiac output, but this is transient for up to 10 minutes. Think about it as a bit like a passive straight leg raise test, which is a very sensitive marker for patients being underfilled, but the effect is transient. There's a decreased functional residual capacity and lung compliance. This is clear because you've got the abdominal contents are now pressing up on that diaphragm and really affecting how the lungs can expand. There will be increased intracranial and intraocular pressure. So that's particularly important when you have patients with, for example, benign intracranial hypertension, or if you've had patients who have had a head injury. When you're thinking about critical care, you actually want the head to be 30 to 40 degrees up to allow venous return. So if you have a patient who's in this Trendelenburg position for a prolonged period of time, actually you might see that the patient looks quite edematous, they look quite swollen. So complications of this are, as mentioned, swelling of the face, the tongue and the larynx. If the larynx is swollen, then that has implications for extubation. You have high airway pressures when you're ventilating the patient, and there's a higher risk of lower esophageal sphincter compromise, and so a high risk of regurgitation. Therefore, it would be suitable to have a patient in this position without a secured airway, so a cuffed endotracheal tube. The thing to think about is that patients can slip when they're in this position. We've already spoke about not using shoulder braces, so you want to make sure this patient is on an anti-slip mat so they don't come off the table. Because sometimes when we put patients in, or when we're asked to put patients in this position by surgeons, it can seem quite extreme. The next position to think about is the Lothotomy position. So in this position, the patient's hips are flexed and the legs are abducted 30 to 40 degrees from the midline. Now, the legs should be raised together to prevent lumbar spine injury, and we should make sure we're padding the lower limb bony prominences. That is essential. For any procedures greater than 2 hours, the legs should be periodically lowered and pressure points checked. So you might have a patient in this position for a lot of gynae surgery, rectal surgery, and some urological surgery as well. This has got some physiological effects, not quite so marked as a Trendelenburg, but a sort of similar flavour to them. So there's increased venous return to the heart. Again, this is transient, causing a transient increase in cardiac output. Increased intracranial and intraocular pressure, not to the same extent as in a Trendelenburg position. Increased intra-abdominal pressure, and flexing those knees is really going to reduce that space. Reduced lung compliance and decreased tidal volumes. Complications for this are perineal nerve injury. That's why it's important to make sure that you're padded appropriately behind the knees and around tibial protuberances. The fingers themselves can be trapped in hinges of a table. So although it's not illustrated in this diagram, typically the patient's posterior is going to be right at the end of a table, and our operating tables have got detachable segments. So what might happen is at the end of the procedure, in order to put the patient's legs down and put them back into the right position, they will add on the segment that has been taken away to allow surgical access. The fingers are there, and they can become trapped. It's not uncommon. There's a risk of lower limb compartment syndrome while the legs are strapped, so not allowing for expansion, and therefore lower limb ischemia. Next position is lateral decubitus. So this is a position where the non-operative side is dependent, with the legs flexed and the knees padded. Looks a little bit like the recovery position. So the torso itself has to be balanced and supported anteriorly and posteriorly. While you're getting the patient in this position, you have to be maintaining the airway and keeping their head in a neutral position. You're going to be putting pillows underneath them to keep that neck from being too laterally flexed. And you're going to make sure that someone has their hands on the hips while you have them in this position and on the shoulders until the surgeons can put in braces and supports for the torso and the hips. The operating table itself can be flexed, and you get into almost like a so-called jackknife position, where either the torso will be flexed down or the legs will flex down. Now, if this is the case, you have to make sure that you've positioned the patient where the point of flexion is under the iliac crest and not under their flank. So indications for this position might be thoracic surgery, retroperitoneal surgery, or hip surgery. This head doesn't have quite such marked physiological effects. You get sort of like increased blood flow to the dependent lung, which will also therefore be underventilated, and you will get a resulting shunt. However, it's not uncommon for the body to be in this position when we're sleeping. Therefore, it's not the physiological consequences of it are not too threatening. Complications of this position include brachial plexus injury if the head is not neutral. Also, you're moving the arms around there to try and get them into a good position and to keep stability. There's a risk of overflexing, overabducting. The axillary neurovascular structures are also vulnerable and exposed. Next position is the prone position, and you can think about this as just lying on your front. So the head can be positioned either to the side or kept neutral, as I've depicted here. The head itself is usually supported by a head rest, which we spoke about earlier. The knees themselves will be slightly flexed, and the arms are either at the sides or as with the palms facing medially, or as I've depicted here, outstretched over the head. Sometimes you can put the patient in what's called a swimmer's position, although that's mostly done in critical care, where you have one hand, as I've shown here, and the other hand is down by the side, and the patient's head is turned. It's important to think that when you have someone in a prone position, you anaesthetise them in the supine position. Therefore, you have to perform a full 180-degree turn on the patient. The anaesthetist is responsible for maintaining a patent airway and performing inline stabilisation during proning procedure. You need lots of patients to prone effectively. When it's done in critical care, we typically have at least 5 patients to perform this, 5 members of staff to perform this. When you do it, you can disconnect the ETT from the circuit, because you don't want that to be a vulnerable piece that might become it might not become disconnected if there's traction on it, and it might in fact pull the tube out, and that will cause numerous difficulties, as you can imagine. Reintubating a patient in the prone position isn't easy. Also have to think about where your wires are, and when you turn a patient 180 degrees, that they're not either falling underneath the patient or that they're becoming twisted or traction is being put on them. We will typically put our ECG monitoring dots will be on the patient's back, as long as that's not interfering with the surgical field. So indications for this would be any operations sometimes on the posterior fossa of the skull, spinal surgery, some perirectal procedures, and operations on the posterior lower extremities, especially thinking about ankle surgery. Physiological effects, not really so many physiological effects. We might elect to prone a patient in critical care to improve their ventilation perfusion matching, and it's part of your arsenal of interventions to perform for patients with ARDS, and I'm sure we've all had an experience through the COVID crisis of patients in critical care being proned. So the physiological effects are somewhat beneficial, but the complications are clear. There's compression of facial soft tissue in the eyes. It's very common for people to get pressure sores if they've not been adequately supported. Corneal abrasion or drying of the eyes. That's why we need to make sure that we can see the eyes, and we're monitoring them every 20 minutes. Post-op visual loss is more common in the prone position. There's a risk of airway edema, and also the airway is inaccessible. So you really want to make sure that you have tied, taped, secured that airway appropriately. The final position that you're likely to see is the sitting position. And this is very much as it sounds. It's an upright position with the hips flexed. The arms are not held sort of by the side, they are supported. That's to avoid traction on the shoulder, and they're and the neurovascular structures. The knees themselves are flexed, and that's to avoid sciatic injury. So the patient's head itself will require specific support, and they're typically taped to this. Indications for this operation would be posterior fossa surgery or shoulder surgery. The physiological effects of a patient being anaesthetised in supine position involve pooling of blood in dependent areas, so it's your feet, your legs, decreased mean arterial pressure and systolic blood pressures, and therefore decreased cardiac output. So you really have to make sure that you're maintaining patients' mean arterial pressure, especially think if you've got if you have a invasive arterial blood pressure monitoring, that you are adjusting it correctly so it's at the level of the right atrium. And complications of being in this position where your airway is typically distant, the surgeons are up around the shoulder and the head. The tube typically will connect to the circuit by running down the patient's torso between the legs and off to the anaesthetic machine, which will be in front of them. So you're not really standing next to the head end. With a distant airway, means that you have to make sure that you've secured that airway adequately and you've checked the connections when you've done that. There's a risk of venous air, or there is a risk that if there is a venous air embolism, then it can go to the, and it's patent foramen ovale, that it can go to the brain. You can suffer a stroke. If there's any shoulder traction, that can result in neurovascular compromise. And cervical spinal cord injury can happen if the head itself is not kept in a neutral position, or if it's not properly secured and moves during surgery accidentally. Risk of cerebral hypoperfusion and patient hypotension. So that brings us to the end of this talk. Just to recap, so we've spoken about the role of the anaesthetist in transferring patients to the operating room, some of the common positions for patients for surgery, and some of the key concerns with specific patient positions. Also gone through some of the other curriculum items that you can link to maximise your workplace-based assessments. Thank you very much. I hope this has been useful. Here's some of the references and link to the program that I used to create those images.